Hello and welcome to another segment of Interviews That Matter. I'm your host Raj Mehta. Friends, in this segment we bring those guests who influence our lives. This includes elected officials, policymakers, heads of major organizations and other dignitaries. It is my sincere hope that the knowledge brought in by these guests will help our community. Today we have such guests. He is Dr. Ramnathan Raju. Dr. Raju is the CEO of New York City Health Plus Hospital. New York City Health Plus Hospital is one of the largest healthcare institutions in the country, with 11 hospitals and 70 other centers. Dr. Raju, thank you so much for coming.
Great to see you, Raj. Thank you for having me.
Really appreciate your time. I mean, you're a busy man, and I know that you do a lot of different things. Serve a lot of people. Huge hospital corporation in the country. So really appreciate your time today.
No, thank you. It's a pleasure to be here, and great to have this conversation with you.
Thank you so much, sir. And normally, obviously, a lot of people know you as a CEO of the largest hospital system in the country. But we want to know more than that. We want to know, go inside that. How did you get there? What happened? How did you get? How? Just answer me.
Yeah. I grew up in India, and I went to medical school in India. Then I always wanted to be a surgeon, so I did my master's in surgery in India. Mm-hmm. Then as it happens in almost in every Indian surgeon, they all want to go to England and become the Royal College fellow. So that is what I did. So became a fellow of the Royal College. Mm-hmm. And then subsequently I came to this country, and I started practicing surgery. I was a general vascular surgeon, and subsequently I did all the things an academic surgeon does. I wrote papers, did research, and taught medical students and residents, and ran residency programs. Mm-hmm. And we also having a successful private practice. And also in charge of a department of surgery at a hospital in Brooklyn. Mm-hmm. Mm-hmm. And so my first taste of administration came in when my hospital in Brooklyn wants to set up a level 1 trauma center. Mm-hmm. So I was given that opportunity to do that. Mm-hmm. And I developed, I was the founder director for a level 1 trauma center in Brooklyn, mm-hmm. which is even today is extremely successful venture for the hospital. Mm-hmm. And also it gave trauma care to Southwest Brooklyn, which didn't have a trauma care mm-hmm. at that time. Mm-hmm. So I was kind of going around in a merryful way, doing the things I love to do. But my moment of revelation came somewhere in 2001. Mm-hmm. Maybe 2000, about 2002, I think. When there was the Institute of Medicine mm-hmm. Is released a publication. Mm-hmm. It is called Unequal Treatment. Mm-hmm. So unequal treatment for the first time mm-hmm. is showed that in this country, mm-hmm. the greatest country in the world, the most powerful, economically vibrant community, the most powerful country in the world, mm-hmm. and most compassionate country in the world, because if you look at Americans, wherever there is a problem, with a tsunami, in Southeast Asia, or it is Ebola crisis in West Africa, or HIV crisis in Africa, or it is earthquake in Haiti, Americans always step up. They collect money, they send people, they give aid, and all those things. But so in this great and compassionate country, there are people who go without health care in this country. So that was shocking to me, because I never ever thought that people couldn't get health care in this country. I thought, because I always looked at the healthcare delivery system through the eyes of myself and my patients. I was always available to them. Mm-hmm. I took care of everyone, irrespective of the insurance or no insurance. And I gave the excellent care. Mm-hmm. So I thought that is what happening in the rest of the country is.
Oh, you assumed.
Yeah. But when I read the unequal treatment, it was shocking. It has got nothing to do with the race or the ethnicity. It has got to do with everything. Right? It's got race, ethnicity. It's got socioeconomic factor. In other words, whether it is south side of Cook County, if an African American population, your healthcare is not as good as anybody else, or it is south central Los Angeles, or is it the white population Mississippi Delta, wherever it is, there is a problem. So I got extremely interested in what we call disparities in healthcare. There are disparities in healthcare. So I have dedicated last 15 years of my life just to address the disparities in healthcare. So that is why I left a very lucrative, busy practice. I went into the public system just to take care of people. That kind of created a thing. So I went to Coney Island Hospital. I became the chief medical officer and chief operating officer. And then I came during Bloomberg's administration. I became the number 2 in Health and Hospital Corporation as a chief operating officer and chief medical officer. Then I got interested in Cook County because there's a tremendous disparities in healthcare in Cook County. So I became the CEO of Cook County Health System. Then when the new mayor got elected, he offered me to lead health and hospitals. That's what we do. Initially, I thought that the reason disparities exist in this country is because lack of access to healthcare for people. But then I realized we create a lot of access, but still the disparities still remained. Then I figured out it is not access to healthcare, it got to be geographically convenient access. In other words, we got to create access to healthcare which is convenient to the people so they can go. If they have to travel miles, or they have to take 3 buses to get to a health center, then people don't do it.
Right.
That has got a minimal effect, but it didn't have the whole effect. Then now I figured out that it has got to be access, geographically convenient access, and also culturally competent access, because the healthcare has got to be delivered in understanding their cultural needs of the people, the ethnicity of the people, the languages they speak, and also the beliefs they have.
Right.
So we need to be sensitive to that, because healthcare is not one size fits all.
Right.
We need to make the healthcare more culturally competent to different people. Then I understood my evolution of it. I understood, okay, it is not just access to healthcare, it is not geographically convenient access. It is just not only culturally competent healthcare. It is also have who delivers healthcare to who. Because in our country right now, the people who deliver healthcare do not look like the people who receive healthcare. There's a big difference. So we need to figure out how do we create. So I am now in the process of creating diversified workforce. We need to create diversity in workforce. We need to have, the people who deliver care need to be reflective of the people who receive care. Otherwise, we will not be able to close these healthcare disparities in this country. So that is my journey from a surgeon to a practicing surgeon to an academic surgeon to somebody who took upon to try to eliminate the disparities in healthcare. Now somebody who is embracing diversity in the health workforce. So that is the journey of it. So I am trying, my best to make sure that it happens. So I am a national voice in equity of care. The care has got to be, I always believe there is no quality without equality. You cannot deliver quality healthcare unless the healthcare is equitable and it is equally given to everyone. So that has been my mission to drive that. And that is what that is the reason I took this job, because New York City is such a diverse workforce.
Right.
And the New York City Health and Hospitals, which I'm proud to lead, is got a very diversified workforce. Because we believe we probably would be able to say that we are probably one healthcare delivery system in which we look like our patients and our patients look like us. I don't think many hospital systems can talk about it. You go to Elmhurst, you will see a lot of people working in Elmhurst are of Indian subcontinent origin.
Right.
You know, you go to Lincoln Hospital, all of them are of Hispanic background. You go to Harlem Hospital, they are mostly African Americans, right? So that kind of how the workforce reflects the people with training. That is very
basically
important.
Right.
That is very important to provide equitable healthcare.
Right.
Because we can't teach people
Right.
how to be equitable.
Right.
It's got to come from them.
Yeah.
That is where my journey was.
Wow. Well, when you first started, I mean, you heard about this disparity in the healthcare system, right? And then, I mean, you decided to kind of, it's a serving people, basically. That's what you're trying to do. Like, you're helping people, you're serving people. Is that something there from the beginning in you, or it just because of you read these studies and that's how it came out too?
No, it was as a physician, not only just me. I don't want to kind of make myself any bigger than I am.
Right.
Every doctor who chooses to serve, he has got a service mentality, right? In other words, my dad used to tell me, to be a good doctor, first you have to be a good man or a good woman. You cannot be not good and be a good doctor, right?
I totally
So
agree.
the compassion comes with being a physician, right? Anyway, right? So it is, but what was different was, I was only worried about my patients, and I was only worried about the effect or the influence I could have on my patients. But I felt it'll take a long time to do this one by one.
Right.
We need to really figure out a national way of how to do it quickly, because as we wait for the disparities to go away, people are dying of preventable death.
Right.
People shouldn't die of preventable death.
Right.
So that is the so it is not something I acquired, but I acquired a much more a global perspective because of the unequal treatment, what I read. But I think every physician wants to serve, wants to do the best for the patients.
Right.
And they try to do it in the difficult circumstances. And they do it without expect any remuneration. Because every physician in this country provide charity care, take care of patients who can't afford to pay for it. So that is very different from thing, right?
It's really similar. I'm sorry. It's really similar thing. What I mean, my story for this show is really like whatever you're looking at. Like how can you help more people? I mean, I also did one-to-one help to many people, but then I thought of how can I help more people in providing knowledge, like whatever you just say to the viewers, right? I mean, outside somebody's looking and somebody's gaining this knowledge, whatever they didn't have. So that's exactly same concept that I started the show for. It's really
I think it's important, because at the end of the day, you get not how much you receive, is how much you give.
Perfect. That's I agree. Very nice. Nice. I agree. Wholeheartedly. So I guess if you, I mean, before I'm jumping into little different area here. That the presidential election this year, obviously, Bernie Sanders talking about universal health care. It's similar to what you just said. Is that?
It is. Conceptually, yes, because everybody should have health care.
Right.
But the question is, who should provide the health care? It should be the government, or it should be a private enterprises.
Right.
Both has got goodness. Government mission brings a mission of the thing, equality, other things. The private companies bring the efficiency in healthcare. We need both.
We need both, right.
We cannot just have mission without efficiency.
Right.
And we can't just have efficiency without mission.
Right.
So that is why I believe there must be a mechanism to bring the private enterprises efficiency into the government's mission-based system. So you're right. A universal health care is absolute must. The question is who should provide it. It should be all government, or it should be government and private, or it should be all private. So that is the issues we are struggling with.
It's a hard balance.
Yes, balance.
It's a hard
Yes,
balance
very
because
hard balance, yeah.
because if you put all government, then eventually corruption
Yes,
comes
yes.
in, and eventually healthcare goes down.
Inefficiency comes in.
Inefficiency
in
comes
the
in, right?
government.
Yeah.
But if you all make it purely private, then
Well, then
naturally
the
sometimes
profitability, look for profits.
becomes, yeah.
Right.
So we need to balance that.
Right.
That is
Yeah,
the
that's-
tricky balance.
That's
Hopefully, Senator Sanders will understand that it's not just about delivering healthcare for everyone. Noble mission, we all with it. But we need to figure out who should deliver it, how should be delivered.
right.
So those are the important points we need to take a look at.
Yep. No, you just mentioned that in Elmhurst Hospital is more Asian in people working there. So basically, the concept is really like a discrimination, basically, right? Discrimination, whether you're providing healthcare or you come for healthcare, discrimination, plays a role. Like we had Dr. Calvin Butts, Dr. Calvin Butts,
Yes,
right? I mean,
yeah.
he's a big, the pastor for the oldest,
absolutely.
Harlem,
Yes.
church on. President of SUNY Wells, Old Westbury, and he's African American, and we're talking about discrimination, obviously, right? Not in healthcare, but generally speaking, right? And I, he's a big shot. He's a very well-known person, and I asked him that, Dr. Butt, do you feel a discrimination? And his answer was yes, and I was shocked at his level. So let me ask you this now. Obviously, you're very high level. You're a big shot. You run $7.2 billion organization. Do you see anywhere it's in healthcare that is it like because of that you're changing this?
No, I wouldn't say discrimination is, at least in a public system, because most of my employees, 40% of my employees are African Americans.
Okay.
20% is Latinos, and 20% is Asian.
Okay.
Right? And 20% is Caucasian.
Mm-hmm.
But what it does, it is not, it is disparities in healthcare is important to me, because sometimes the disparities in healthcare cuts across, the color, the ethnicity. It also cuts across other things, right? People are discriminated against, in all over the world. That unfortunately happens even in our country. Sometimes you're discriminated based on color, sometimes you're based on ethnicity, or sometimes you're discriminated based on
Economic.
your sexual preferences or orientations.
Right.
That's a big issue. Or you are being discriminated based on sexual identity of the person, and you're also discriminated based on poverty.
Right.
On the socioeconomic conditions.
Socio-economic conditions.
You are discriminated based on availability of immigration status.
Right.
You're being discriminated based on so many other things, right? It is all depends on where you live and what you do. So, yes, I think the idea is that discrimination ends up at disparities in healthcare. Right. They're not able to get the healthcare they need, where they need it, the time they need it. So, I think the lack of opportunities and the lack of ability to play a vital role in the communities and society is a bigger discrimination, because anybody should be given opportunity to play a vital role in the communities where they live. If that vital role is only reserved for a few people, it doesn't allow you, based on whatever it is, based on immigration, based on color of skin, or based on ethnicity, based on language, anything. But I think we need to get over that. Right? We need to figure out how to. So I look at it from the disparities in healthcare. It bothers me. One issue is the racism and the color, but other issues also need to be addressed. That's why the mayor has said, which got me interested in this job, is the mayor has said the tale of two cities. There are two cities in New York City. The idea is how to bring them together as one city.
Wow.
So that is the more important things to us. It could be based on so many different things.
Right.
Definitely, Mr. Butt, who is a big leader, and he is right to feel that it is racism. but it's also other things.
Right. So let me come back to now your current challenge, rather. You know that you got appointed in 2014 early, right, by Mayor de Blasio, and obviously, you know, you've proven yourself in Cook County Hospital as a CEO. You saved a lot of money over there. You restructured everything and all that. So that was very nice. Congratulations for that. And also, so 2 years have passed by. So in 2 years, what did you face? I mean, what did you change first? Like, you know, when you came into the job day one, I mean, what were your...
You know, what I am trying to do is, the work is not complete yet. We have two major issues, right? Our issue is the financial stability of a public system,
Right.
ability to provide health care, to keep its mission intact, right? We serve 1.4 million New Yorkers.
Right.
In other words, 1 out of every 6 New Yorker is our patient. Of this 1.4 million people, 475,000 people have got no insurance.
No insurance, right? Yeah.
Right.
Right.
So we need to serve them, and we need to take care of them, because they can't be left out of the system. That's our mission. We turn no one away. We take care of everyone. Then where do you find the money?
Right.
To take care of them, right?
Right.
That is
That's
the first part, right?
Right.
I need to find the money
Right.
to take care of them
Right.
in a way so their care is comparable to any other care in New York City.
Right. Right.
That's one. The second part of it is, as we are doing this, the healthcare delivery system is also changing, right? Healthcare was more about inpatient care. That's why we built the hospitals. That's why we built the service lines, everything. Now the future healthcare, what was used to be done in the hospital in the last decade, are now done as an outpatient.
Right. Exactly.
Right.
Yeah.
So I remember those days when you go to a hospital for gallbladder surgery, and you stayed in the hospital for 10 days.
Right.
Now these things are done as an outpatient.
Right.
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 And major cardiac events, surgeries are done through, catheters, and able to do non-invasively, able to get it done.
Right.
So it is, and the second part of it is also, we never really had health care in this country, I would argue, because we always had sick care. We paid people to take care of sickness. We never really paid people to keep people healthy.
Right. Right.
So
right,
that is
right.
changing now, right? People are saying, wait a minute,
Right.
why would I pay somebody a sick care?
Right.
I should really pay for real health care to
Right.
keep people healthy.
Right.
So as the healthcare market is changing around me, and the financial pressures are still on the public system, how to provide care for people who can't afford to pay for it, are two major challenges. So I needed to do two things at the same time. I need to find some financial viability,
Right.
Stability for the organization. At the same time, I need to change the organization from a very inpatient-oriented manner, a sick care model, into an outpatient-oriented healthcare model.
Right. Right.
So
right,
that is
right.
what I am trying to do now.
Okay.
Right?
Okay.
I'm trying to move away. The hospital, as it has been in the past, will have no relevance in the future, because it's like, just imagine, it's like going to 10 years ago. If I come to you and say, I want to go to a bank,
Right.
that means what I did was, I basically went to a building, and I sat, and there were a lot of tables with some pens. I pick up a slip, I wrote my name or whatever it is.
Right,
I
right.
stood on the line, I went to a teller, and either I can transfer money, or I can withdraw money, or I deposit a check.
Right. Right.
Today, going to the bank simply means I open my smartphone,
Right.
take a picture of my check,
Right. Yep.
and then deposit that.
Deposit. That's it.
And if you want to change accounts, money from one account to another account, I just go there in the smartphone and change it.
Right.
So, do you think in the future the banks we constructed, big buildings with all this thing, you think they have any relevance in the future? No, people are going to be done differently.
Right.
The same thing will happen to the hospitals. So the hospitals in the future will have no walls. In other words, Bellevue is not just a structure. Bellevue is a community it serves. Elmhurst is not a structure, building. Elmhurst Hospital means that it expands in community. So the future hospitals will have no walls. It kind of moves into the communities where it is convenient care, culturally competent care, easy access. So that is what the future is as an organization. So that's what we are trying to build. We are trying to build more access in a geographically convenient areas, which is culturally competent, and people can come in and get care. And we are moving from a sick care model to a health care model. So that is a big changes, right? Because we have really had this similar model for 60 years in this country. Now we are moving in a different model. So those are two big, issues I am facing, and I'm trying to solve it for my system.
So it's like, opening centers outside of hospitals. That's when people we had Michael Dowling here. He runs Northwell.
Yes.
It's a lot of hospitals under him, and he also mentioned similar thing. What you just mentioned, that like rather than going to the hospital where the cost is high, where everything comes higher, and rather than you just go to a small center, get it done, and go.
And also the future may be different. In other words, there may be a time will come when you can probably just touch your smartphone and you can video conference with the doctor and tell him, I have this, what do you think I should do? Should I come and see you or should I go somewhere else, right? We do telemedicine now. We do video conferencing. We do video consults. All those things are going to change the way the hospital is constructed, right? So healthcare has got to change fast. It has got to change very fast because the future is not about big hospitals and big centers. It is all about community-based centers, IT, teleconferencing, able to get advice on your smartphone, able to make your decisions, buy your medication, whatever it is. They're all going to be made much more convenient.
So right now your focus is on transformation and finance, correct? And finance is obviously it probably you've changed a lot of things in order to make it more better, right? And creating more community-based centers, kind of. That's what your focus is right now.
And the idea of finances is also that the public system need to compete with the not-for-profit systems. The way we need to compete is we always give excellent care. The quality of the public systems are comparable to any other systems. But where we need to improve is our patient experience. Patients should not be waiting long time. Patients need to have better ambience. Patients needs to be answered quickly. And the attitude we exhibit towards them need to be better. All those things are what we call the patient experience. It's not just enough you give good quality care, because that is given. When you want to get health care, everybody expects good quality care. That's not something you can sell anymore. And they sold it for 20 years. I give you better care. No, everybody gives better care now. The question is your experience of receiving the care any better? Is it better here or better there? That is the issue. So I am concentrating on the transformation is getting more market share. Our ability to compete with other systems based on better patient experience. And I have one great advantage. As I said before, my system reflects the communities I serve. They speak the language. They understand the cultural background. They understand their beliefs. So I will use that as a leverage to come and come to my institutions. In health and hospitals, we speak more than 170 languages.
Wow.
Anyone comes from any part of the world. I probably will assure you that I will find somebody either they speak the
Communicate,
language
right.
or somebody who came from a similar part of the country,
Right,
of the
right.
world.
Wow.
So we have our diversity in our workforce is the greatest asset we got, and we need to leverage that to get more market share.
So, like when you already serving 1.4 million people, and obviously, there are other hospitals,
Yeah.
which are non-profits or,
Yeah.
for profit. They are also your competition, basically,
Yes,
right, to attract
yes,
patients and all
yes,
that.
yeah.
So, what is the room now? Is there what, huge room?
The question is, yes, it is. There is a room in the sense that the Affordable Care Act, so Obamacare,
Right.
has actually given more insurance to more people.
Right.
Right, and also they have added more plans like essential plan. The people who just makes a little more money than the threshold for Medicaid eligibility. They're still poor. They
Right.
can't afford to buy expensive insurances in the marketplace.
Right.
So we have an essential plan. People just make a little more than Medicaid, but up to 200% poverty limit can get insurance very, very cheap. Right. So that is another group of people who are coming into care, and it also depends on what segment of the market you want to serve. Right. The market segment, there are people who serve very high-end, patients and
Right.
high-end services.
Right.
I really want to take health and hospital into in ambulatory care, community care, population health, and and secondary care, all those things, where we will dominate the market. Not on tertiary care. We may not dominate the market on heart transplants, but we will dominate the market on how to take care of diabetes in the community. Right? That's important. So we need to we have some advantages because we understand the community we serve, and I can quote multiple examples of how we are done with that. An example was in Kings County, which is in the middle of central Brooklyn.
Right.
We serve a large number of West Indian American population, and if you want to control the diabetic, you need to teach them how to cook their own ethnic food and still be compliant with diabetic diet regulations.
Right.
If you tell them, and if you tell me, you can't eat rice at all, that is going to be difficult for me because that is my staple food.
Right.
So healthcare cannot be just say, okay, I don't care, you're a diabetic, no rice, this is what you need to eat.
Right.
People don't follow that
Right,
because
right.
we need to figure out how to make people eat their food,
Right.
but at the same time stay compliant
Right.
with the diabetic, whatever regulation restrictions we have, in the dietary restrictions we have. So to understand that, you need to understand the community. Otherwise, you're going to just give them a piece of paper and say,
And that's it.
this is the diet,
Right.
eat the diet, don't eat anything which
Right.
is not in this
Right,
paper.
Right.
That's not going to be.
They're going to come back again to the hospital with the
hospital.
problems.
So we understand the communities, we understand what the issues are, we understand why somebody is not improving, because we don't believe that they're not improving because they're non-compliant. It's not their fault.
Right,
We
right.
need to create a system which addresses their individual beliefs and their practices and the dietary habits
Right.
and try to incorporate into them. Right? It's like, everybody has to buy the shoe that fits them.
Right.
You can't get a shoe and cut everybody's foot
Right.
to fix it, right?
Exactly, yeah.
So some of our protocols and our things are all too rigid. We just make, this is what you need to do, so everybody cut your foot because this is the only size we're going to give you. That is not the way to engage people in healthcare.
So, 42,000 employees. I mean, you're leading 42,000 employees. And the challenge is really that whatever your, vision is and your views are, like trickle down to the last employee on the, so that's probably a biggest challenge for you, I guess.
Communication continues to be a big
Right?
challenge.
Yeah.
And,
Yeah.
I hold a lot of town halls. We have, brochures, pamphlets, emails. We use everything possible.
Right.
But still, the information does not reach people we need to reach.
Right.
So I used to be, I was telling somebody, in a humorous way, a few weeks ago, I said, every time I tell someone, don't tell anyone, everybody knows about it. When I send a communication saying, please read this, nobody reads it. Maybe I need to say a reverse psychology. Maybe I should tell him, this secret, don't tell anyone. Then I'm pretty sure that 42,000 employees will all know the next day. because I think it is tough. It is tough with the communication of such a major hospital system. And also, the communication two-way street. It is just not that what I tell them.
Right.
They also have to assimilate and identify themselves with what we are trying to do.
They have to agree.
Yes, they have to agree, and they have to buy your vision.
Buy in, right.
They have to buy, my vision, our vision. We need to do this. So that is tough. It takes a lot of time.
Right, because I mean, we in IT, right? The biggest, I always say to people that, listen, technology I can create it, no big deal. But when I have a problem with change management, that somebody has been doing this for 10 years.
Yes.
And then I have to tell them, no, don't do it this way, now do it this way. That's the problem.
You're absolutely correct.
And that's the biggest issue, I said.
That is the culture. The culture of the organization is very important. Because people always, you heard these multiple people say that, culture, eats a strategy for lunch every day. Right. Unless the culture of the organization need to change. Right. The culture is, we need to know why are we here today. We are here to take care of people. Right. And are we doing that today? So that is the issue. Right. We need to give them a purpose. The purpose of why we are here in this world. What is our job? What is our role? Right. If our role is that we want to comfort people who are sick, who are in pain, who are anxious and worried, then that's our job. Right. So we need to really work on this. So if people ask them, we are, a part of medicine is not about just the science. Is also about compassion, empathy, respect. Absolutely, and ability to do that. And that is very, very tough because we developed a healthcare system in this country. We developed a system based on diseases, not on individuals. Right. We are very good in treating diabetes or a cancer or whatever it is, but we should get better at treating the person who happen to have diabetes. Right. So we are not treating diabetes. We are treating John who happened to have diabetes. Right. Right. Very, very good way to see. So that is the way we need to see healthcare. Right. We cannot just see healthcare. Right. So if I see John, then I understand John better. Right. Right. Then I treat diabetes better. Right. If you only look at diabetes, not look at John, right, then I'm not going to be successful. Right. Right. Wow. It's a good way to think about it. Really. Yeah. I also want to touch upon, like, you have 1/3 of your population, 1.4 million is uninsured, obviously, and that's a big cost to all the hospitals, and that means there is no income from them, obviously, right? So then to balance your books, I mean, that will be a biggest challenge for you, really. Yeah, it is. It is a challenge in a good day, but now the healthcare under the Affordable Care Act, things are changing. Okay. Because what is happening here is people felt that if we are going to, normally what happens is the public hospitals get a subsidy from the federal government. Right. And they give us just to take care of people whom we couldn't, bill and collect money. Right. Right. But under the ACA, people need to find out how to fund the ACA because that's going to be expensive because you're giving insurance to a lot of new people. So somebody has to pay for it. Right. Somebody has to pay. So somebody came up with the idea saying that if we are going to give insurance to everybody in this country, then we don't have to pay for the uninsured people because there will not be any uninsured people anymore. Right. Right. But that is a faulty notion because ACA in spite of his best intentions,
Right.
probably one of the best thing we ever did in healthcare in the last
Right.
century,
Mm.
is if you're undocumented,
Right.
or even if you are documented but you are not here for more than less than 5 years,
Right.
then you cannot be a participating ACA.
Mm. Mm. Mm.
So it left behind a large group of people who are undocumented,
Right.
right, or who are not
Right.
eligible for ACA.
Right. Right.
They need care.
Mm.
Somebody has to pay for it, but you're taking the money away,
Mm.
which traditionally paid for their care. So
Mm.
that made it very difficult for us.
Right. Yeah.
Need to find out where we are.
Mm.
So
Mhm.
we are trying our best to
Mhm.
bring in more efficiencies in the system, right? A better management of our supply chain, managing, our workforce better, and making sure we cut the waste,
Mm. Mm.
bring the length of stay down.
Right.
All
right.
those things we are doing, better revenue cycle improvements.
Right. Right.
But
Right.
all those things will help us, but
Mhm.
will never be able to pay for that. Close to 500,000 uninsured people we serve.
Right.
So
Right.
that is where I am taking a national level position on this,
Mhm. Mhm.
that we need to do that.
Mm.
And the ACA also, has got unintended consequences, because what it did was,
Mhm.
there are people who just fall outside the Medicaid,
Mhm.
but they can't afford to pay for the premium.
Mm. Mhm.
So what people do is, people take a health plan
Mhm.
which offers them the lowest premium.
Right.
But the problem with that is they come with a very high deductible.
Mm. I know.
And
yeah.
they will never have the money to pay the deductible.
That's right. Yep. Yep.
So
yeah.
those people are being taken care as uninsured,
Right. Right.
because they will never be able. So they use that
Mhm.
particular insurance purely as a catastrophic insurance,
Mhm.
not for regular health care, because they
Right.
will never be able to.
Mhm.
If you are making 50,000, whatever it is, but you will never be able to pay $5,000 or $6,000.
Right. Right. Right.
As a deductible for
Right.
you and then everybody else. It's not.
Yeah. Yep.
So there is a group of people who have insurance
Mhm.
but couldn't really use insurance because they will never meet the deductible.
Deductible. Right. Exactly.
Right? And they will never be able to pay the co-pays they need.
Yep. Yep.
So the best way to get care when you need care quickly is to go and say, wait a minute.
Mhm.
The government is trying to help them. They're basically keeping some of the primary care services free. Not
Right.
You don't have to co-pay for that.
Right. Right.
But people are worried because it's also with the healthcare cost, a major portion of healthcare today is pharmacy cost. Pharmacy costs are very high, and people are sometimes people just don't take the medication because they couldn't pay
They couldn't pay, right, they
the
couldn't buy
extra
the
cost
medicine, yeah,
medicine,
yeah,
right?
yeah.
Even though insurance
Yeah.
covers the medicine, they still have to pay
Right.
the extra money to get whatever need to be done. So
Right.
we have to work very, very hard.
Mm.
We need to come with a very innovative ways. We are really a group of very smart people.
Mm.
So we can really make it work better.
Mm.
For the amount of money we spend in healthcare,
Mm.
I firmly believe
Mm.
we can give a better healthcare
Mhm.
to everyone.
Mm.
But we need to figure out how to do it correctly.
You mentioned just now. We talked about the cost of pharmacy, cost of medication, right? Obviously, it's very high compared to a lot of other countries. Like people, I've heard that people are buying from Canada medication. People are buying going to India. In fact, India manufactures a lot of medication, which is same as here, like Crestor, for example.
Yeah.
Crestor, right? Crestor in India is much cheaper than Crestor here. And obviously, research costs and everything goes in until their, whatever the license is over, something like that, right? So, is there a way to reduce that cost? Like you said, many times people don't even take the medication because of the
Yes.
cost. So, how can you, like, for example, can they buy from outside, or does your hospital give them that suggestion or something?
No, in the public systems, we have a program called 340B program, right? So
Okay.
the government gives us, allows us to buy the medication in a discounted way
Okay.
because we are taking care of poor people.
Okay.
But
okay.
the escalating pharmaceutical cost
Right.
is a major concern
Mhm.
for all healthcare leaders in this country, because a part of the increased expenses in healthcare
Right.
is due to increased pharmaceuticals and also expensive pharmaceuticals.
Right. Right. Yeah.
So we as a country need to come to terms with, right, how do we, keep the cost down
Right.
of pharmaceutical cost,
Right.
right? Just like we are trying to figure out how to keep the inpatient cost down, how to create a system that helps, people to get the pharmaceuticals, but don't have to spend life savings to do that. So all the other things like importing and trying to get the medication from other places, right? That people get into that because we don't have an effective mechanism
Right.
to curb the cost of pharmaceuticals in this country. So people naturally go outside and do that.
Right.
So I think the question we need to be careful about, right, is some of the pharmaceuticals in certain parts of the country or the world are very, very good. They are very good mechanism. And some of them are not as good because they don't have the right strength, the right dosage, the right ingredients. So we need to be careful. But I think we need to really work very hard to get the pharmaceutical cost down in this country. Otherwise, people will make the diagnosis, they find out what is wrong with them, but they can't get care of them because they can't afford to pay for the pharmaceuticals. So that is something we need to watch for. And hope the future governments will have a much more effective policy of curbing the pharmaceuticals in this country, of cost of pharmaceuticals in this country.
Let me ask you this, because I'm not too knowledgeable, obviously, but I'm going to ask you this because we had a guest here. He was a scientist, and he actually for the Cold Spring Harbor Lab. So they do research on genes, human genes, right, and genomes rather. So what, according to him, that they're doing research on like, for example, each person will have a customized medication.
Yes.
So for example, if somebody needs only 250 milligram of something versus they are giving 500, there's no need to give 500 milligrams, something like that, based on their genes. And if that happens, that may be the one way to cut the cost of pharmacy, because you are not giving extra to people. Is that something that you think?
Genomic project is a very exciting aspect of science.
Right.
And it is going to modulate the treatment to individual people so that you're able to do it individually.
Right.
You're right. But the problem with that is we make pharmaceuticals with some standardized dosage schedule.
Right.
So there is nothing you could do. For example, if the medication 250 milligrams, right? You only need 60 milligram because your body reacts to it much more differently.
Right.
They don't make a 60 milligram tablets.
Oh, okay.
Right.
Okay.
So you don't have that kind of the luxury. We need to either again, as I was telling, it's about buying a shoe and fitting yourself into that.
Right.
Then we talk about what we call side effects. Right. Then we said, okay, God, we have a side effects here because this is what it is. Because we are not customizing the dosages to level. And also, sometimes the dosages difference doesn't make a big difference in the cost.
Right.
Right? But where it will be very effective is the fact that people react differently to different medication. Right? The reason we have 50 different high blood pressure pills in the market is because people react differently to different pills.
Right.
If everybody gets the same effect, then we'll have one pill.
Right.
So that shows you that people are different. One person gets well controlled on this particular pill A.
Right.
The next person, it doesn't do anything at all.
Right.
He needs pill P.
Right.
And then pill C and pill B, whatever it needs to be.
Right.
So that will be effective, right? That has to do something with the genetic materials.
Right.
It has got to do with how the medication get absorbed in your system, how
Right.
it get metabolized in the system. And,
Right.
So we need a lot of work on that, because at the present time we believe that if we give a medication on a particular dosage, it's supposed to help everyone. The dosages are at the present time are predicated on the weight of the person. That's a very crude way of measuring dosage, but that's the best we got.
Right, right.
But in the future, it's not about your weight; it is about your body's ability or reaction
Right.
to responding to it. Because
Right.
the medication is only giving medication only one part of the arc.
Right,
The
right,
other
right.
part of the arc is
Right.
how your body reacts to that.
Right, right.
And we really do not have that that kind of mechanism. So every time we feel that the medication is not effective, the first thing we do is increase the dosage. Then we increase the dosage. Then we add a second medicine.
Right.
And then we add third medicine.
Right.
If somebody could tell us upfront that
Right.
this medicine A will work because of genetic makeup,
Right.
and medicine B will not work
Right.
because it does not have that particular enzyme which
Right.
will convert that into active metabolized to manage it, or it will not work because that will not get absorbed in the system because of some reason. Those kind of sophistications need to come into our system, right? What we call a pharmacodynamics is need to be a little bit more refined than what we have now. But we got what we got, but we need to be. So the exciting part of genomic study is not just what the medicine is supposed to do and how the body reacts to the medicine is as important as the medicine they're giving.
Yep. So I think you're very right. I mean but hopefully like with the new practices, the medication dosage will also change.
Yeah, absolutely.
Hopefully, hopefully
I
they'll do
think
that.
there's a lot of
you
new
know,
medicines
things
are
like
coming
that.
up, new ways of
Yeah,
thinking about
right,
it. So
right.
those are all exciting
Right,
part
right.
of medicine.
Right, right.
I still remember that when I started, my practice. When I first became a doctor, we had a very limited pharmaceuticals we can use with. Now there is so many available all over the place. So things are moving in the right direction, but anytime the science is only as good as the people use the science.
That's right.
So we need to use the science
Right.
the best way. We can create the best possible science. If we don't use it the right way, the science will not be effective. Like any part of every science is a dual-edged weapon. We have to see the goodness and the badness. So we need to figure out how to harness the goodness, right? And they try to reduce the amount of weaknesses in a system.
That's more communication, more understanding, more communication. Keep communicating, keep
Yes.
talking, right?
Yeah.
I mean, so
Absolutely.
that's the key, I guess. The cost of any kind of procedure here in US, it's like, for example, I've heard nowadays a lot of procedures are being outsourced. Outsourced meaning that patient would rather go to India and get it done much cheaper and better, and then doing it here. Does that affect?
It is kind of, for elective surgeries, there is a travel medicine where people travel to foreign countries where they get these procedures done much cheaper and in a better environment. It is being there as a part of it. So, in the past, people used to come to this country.
Right.
That's where the best medicine was.
Right.
Now the medicine becomes so global, right? You could replicate the same kind of technology which is available here is available in some places.
Right.
So that is a huge competition for the healthcare delivery system, because the way we manage the finances of healthcare system is we do what we call cost shifting. We cost shift from private insurance, which pay a little more, to the government insurance, which pay much less. So we cost shift that. And we also cost shift from elective cases to emergency cases, because emergency cases cost more than the elective cases. Right. So it helps you to manage that. So when we are in a system where all the elective cases are going to be going outside the country,
Right.
and you're only going to take care of emergency cases alone,
Right.
the cost is going to go up. So we need to figure out how to offer the same kind of amenities
Right.
which are offered in those foreign countries. You know, I heard people say that they go in, have a thing, they have their own nurse available to them, and somebody take care of them. A few days later, they recuperate in one of those nice beaches somewhere.
Right.
And those kind of things are really enticing for people to go ahead and get it done. But the flip side of it is that it is all good so long it goes well.
Right. Right. Obviously.
If you have a complication, then you cannot go back again.
Right, right, yeah. So, you know, like many of these universities in this country has affiliation with other universities in other countries, foreign countries, and they're doing it this way. So similarly, maybe in one day, in a hospital also will become that way. Like, you know, you may have an affiliation with Apollo hospitals in India, and you might be sending patients from here to there. It can happen, right?
Oh, yeah, I think like a business has become global.
Right.
Healthcare business may also get global at some point where it is going to happen.
Right.
And it is the ability is how do we produce the same amount of quality available to everyone in a foreign country. So we need to strive for that. Because what normally happens here is there is a lot of co-mingling and the ability to replicate the great medicine which we practice in this country in other parts of the world.
Right.
But we need to make sure that it also reaches the people in need. It does it available to everyone, or it's going to be available only to select few in a part of it. That becomes again another equality question, right? So, do we believe as a human race that everybody should get health care? Or we believe as a human race that some people will not get health care and they just have to die early? Right? That is a moral question. It's not really a business question.
Right.
It's a moral question for us. Right? So what is the role of the society in providing that? Should we worry about people who really die younger or suffer because they couldn't get into healthcare? That's the issue.
Yep. Let me ask you this now. I've also heard the effects of yoga, you know, in patient care. And in patient care, I mean, I've heard that the patient improves faster using yoga techniques and yogic, you know, like a meditation or things like that. And some of the hospitals here, you know, in Northwell, Michael Dowling, I mean, he has already indicated they're incorporating that yoga also into their, you know, patient care. Do you believe in this? Do you do that?
You know, I think Western medicine developed as an acute care medicine. So Western medicine is very, very good in acute events. We know how to take care of them. We know how to pull people out of their deathbed. We need to do that. The Western medicine is not as effective in the chronic diseases as, you know, at least some of the chronic diseases like arthritis, other things. There is really no effective way of able to deal with it. Eastern medicine has got a lot of untapped potential, right? We have done that. It's known to be effective, and I'm very happy to see that more and more research is coming out because medicine is a science, and people will not follow unless they see some real demonstrable benefit in a reputable research project. Right. So I'm very happy that's coming up. A lot of people are doing research on yoga and some of the other Eastern remedies, which are found to be very effective. So I think we need to combine the Western medicine and the Eastern medicine together. Something Western medicine is very, very good, and something Eastern medicine would be very good. So we need to create a medical school where you are taught both. So that you have more things on within your capacity to get things done for the people better. So I think the days of just saying, a modern doctor, MD doctor, then there's an Ayurvedic doctor, then
Right.
there's a Siddha doctor, then there's, I think that need to go away because there are good parts in every one of them.
Right.
And we need to figure out how to incorporate them into the care. It's not about, again, as I went back before, we talked about, it's not about disease, it's about a patient.
Right.
So the same way, it is not about, what type of health medicine you practice.
Right.
It is practicing for the patient,
Right. Yep.
right? So I only hope that the medical schools in this country will start looking at some of the Eastern, remedies, which has been there for many, many, many centuries,
Right.
proven to
Right.
be effective,
Right. Right.
Whether it is, an acupuncture from China or is it, so many remedies from India.
Right.
I think people need to do more research into this, more background check on this, making sure that those things are good. If they're good, they need to be incorporated. I think I'm very happy to see, Frank, that more and more healthcare leaders are understanding the effect of yoga and trying to incorporate that into
Right.
a regular, healthy regime of themselves. I think it's a good thing. But more and more things need to come. Please.
Let me move to now presidential election this year. Obviously, biggest election in U.S. history. Lot of excitement around many different candidates, and everybody has their own healthcare plan. Like if you talk about Republican side, they don't like Obamacare. They're going to repeal it. They're promising that. And on a Democratic side, like Bernie Sanders, we talked about it, that he wants to go on universal healthcare, and Hillary Clinton may have her own plan. I mean, I haven't heard, but maybe she has. She won't continue with Obamacare probably. What are your views on candidates and their plans?
It is first of all, this is probably a unique election because you're so confused by it.
Exactly.
Because we couldn't really figure out what is. Sometimes we're not able to even figure out what the difference is, right? But then you and I have been in this country for many, many years.
Right. Right.
What they say to get elected is very different from what they do when they are in office. So
True.
I always
Very true.
take that. So whatever the plans they have, right? For example, when the president he was in a primaries, he did not like this Affordable Care Act at all. He didn't like the individual mandate. He didn't like many things. But then he became the champion of that. Right? So things do change. So it's very difficult to predict what kind of healthcare policy they will practice.
Right. Right. Right.
But the issue is, at the end of the day, right? It is not about what healthcare you're going to give.
Right.
It is about who you give it to.
Right.
Right. That is the fundamental issue with it. Right. At the same time, we need to have healthcare which is cost is manageable.
Right.
So because we can't, healthcare costs escalating at the rate. At the end of the day, we're going to be spending a large portion of our GDP on healthcare alone.
Right.
Then that comes at the expense of other infrastructure projects, right?
Of course.
Our highways, roads, and buildings, and bridges, and all those things. So, so we need to provide healthcare. At the same time, we need to be efficient, and we need to be mindful of the money and not waste healthcare on things which doesn't make a difference. So coming back to that, I think if Secretary Clinton gets elected, she is saying at the present time she will keep the Affordable Care Act and develop on that. And Senator Sanders says that we need to give healthcare to everyone. We talked about it before.
Right.
And then on the Republican side, everyone is very focused on repeal and Obamacare.
Right.
Some people believe that we need to repeal, but we need to replace it with something else.
Right.
And what the something else is, no one has defined it yet,
Right.
what it is.
Right.
But the fact of the matter is, it's very difficult to put the genie back in the bottle again. Because certain things are Affordable Care Act. For example, covering for pre-existing conditions.
Right.
you can never put that genie back into the bottle again. That
Right,
is that's
right.
that is out, right?
Right.
So the minute you tell the insurance companies
Right.
that you need to cover everyone and you can't discriminate based on previous illnesses, the risk becomes much higher. So when the risk is automatically, transferred back to the members, the enrollees, that simply means they get higher premium,
Right.
and the premium must pay for it. 'Cause that is insurance, right? Basically, people who are healthy pay for the people who are sick,
Right. Yeah.
right?
Yeah.
So that is why I believe that if you keep more people healthier,
Right.
then
Then it's
you'll be able to manage the people who are
Right.
sick.
Exactly.
So long we never really worried on it. We only worried about sick side of
Right,
it, right,
right,
as a
right,
part of
right,
it.
right.
And we kept on increasing it. So I think after all the rhetorics and election noises go down, I'm sure there will be the good heads will prevail, and hopefully they'll come to a very rational healthcare delivery system in this country. Healthcare in this country need to be improved. The waste has got to be cut, but we have to do it in a very, very thoughtful, methodical way. Because this is not like changing it overnight. Because if we do that, people get hurt. End of the day.
What is your day look like? How long? How many hours you work in a day? 20 hours? 18 hours?
I put on long hours, but that starts from my surgical days. So naturally, I always woke up at 3 in the morning. So I still
3 in
do
the
that.
morning?
Yeah, still I do that.
Wow.
And I kind of work during the. I usually go to my office around 6:30, and then I leave my office by about maybe around 6:30 in the evening. Then we always have something else.
Exactly,
like,
events and this and that.
Usually some occasion. Most of them work related.
Right.
It's about doctors and nurses are doing something or talking to somebody about it. So
Right,
it's all repeated time. So I think I probably rest around 8:30 or something like that. But again, you are really on call 24/7 because if something happens in the city, if a police officer gets hurt, right, then naturally
Then
I need to respond
need
to
to
that
respond,
as a
right.
part of it. So, but it's exciting. It's one of the best jobs I ever had, and I'm very happy. And I only hope that it's not about the job, as my dad used to say. It is what you do with it.
Right.
Right?
Nice. Yeah.
So I hope I
Very
will do better with this job,
Yep.
better for people than what I've done so far.
Well, we wish you all the best.
Thank you very
You have a
much,
good
Raj.
heart, and
Appreciate
that's all it matters really.
Thank you very much.
Yours
No, the
of this-
final message is I think healthcare, I believe strongly, it should be a fundamental right of the human beings. It should be a civil right. It should be a human right. And if it's up to me, I think healthcare should become constitutional right. People should not go bankrupt, or people should not afraid to seek healthcare because they can't afford it or they
Right.
can't pay for it. So we, as a country,
Right.
need to step up to that, and we need to make that happen. We cannot, just like we say, public safety is important because we don't want people getting shot and dying in the streets. Public health is also important because we don't want people dying unnecessarily of diseases which could have been prevented. So I think people need to understand, everybody wants United States of America to be a great economic power. I don't believe there will be a great economic power unless we have productive people, and you can't be productive unless you're healthy.
Wow.
So health is the bottom line on everything in our lives. Because you can earn money, you can do whatever you want, but you can never ever earn health.
I totally agree. Thank you so much.
Thank you very, very
Really
much.
appreciate it.
It's a
Thank you
pleasure.
so much.
Thank you for
so
the
much.
opportunity. Good. Thank you.
Thank you so much for joining us today. If you have any questions, comments, you can email me at rajmitv@gmail.com. That's again rajmitv@gmail.com. You can also watch our prior shows on YouTube at youtube.com/Infosys International. That's again youtube.com/Infosys International. Until next time, have a great week.